Ladies and gentlemen, welcome back to the Digital Orthopedics Conference COVID-19 Orthopaedic Response. This event is brought to you by DOCSF, but we're joined by the American Academy of Orthopedic Surgery in our discussion, and we're incredibly excited to have them with us, and in particular to have Dr. Joseph Bosco, the incoming president of the Academy, joining us today. He is the president of the Academy and also the professor and vice chair at NYU Langone Department of Orthopedic Surgery. He's going to talk to us about the Academy's position in COVID-19 and their efforts to help us manage this epidemic. So without too much further ado, in fact, I'm going to turn this directly over to you, Dr. Bosco. Welcome to the conference.
Thank you, Stefano. Really, before we go, I'd just like to congratulate you on an amazing meeting. You know, I've been on webinars and they say, or conferences, oh, you have 250 people. That's great. You have over 4,000 folks. That's really amazing. Congratulations. And
thank you, sir.
Very well organized. Yeah, you're welcome. So today we're going to take the next, half hour or so to talk to you about what the AAOS Academy, your Academy's action plan is revolved around the COVID virus. I'm going to talk for a little bit, maybe 10 or 15 minutes. Then he's going to speak as well, and he's going to talk about more specifically about our advocacy plans, because really a lot of it revolves around advocacy. So Jordan, next slide, please. So initially this kind of was the COVID our strategy. But this is more than a strategy. This is an action plan. And, we spent many years, 2 years exactly, and a lot of capital coming up with a strategic plan. And any organization, big or small, if it really wants to self-actualize and be the best it can be, needs to have a strategic plan. That strategic plan has goals in mind and ideas and things that you really strive for. And you have to be disciplined and stick to that plan, or else you get pulled in every direction, and you know what? You get nothing accomplished. But when a sentinel event like this happens, COVID-19, you can't die on your strategic plan, right? You have to be able to pivot off of the plan and be nimble enough to say, okay, we have the strategic plan, it was great, but now we have this crisis that we have to deal with. And I've been very proud of our organization, the way they've been able to pivot off of this plan temporarily and really come up with a cogent action plan on how the Academy is going to work to help its members survive this crisis. And really the plan, it revolves around three major components. One is practice management. And what I mean by that is, helping practices get through this period. And, in New York anyway, they say that it's going to peak in 2 or 3 weeks. And it's still going to take a while to get better. So, we may not be able to do elective surgery for a long time, and there's no patients coming in. So how are these practices going to manage themselves so they can make it through this period? So, and we realize that's of utmost importance to our members. It's almost an existential issue for our folks. And then sort of piggybacking on that, and a component of that, and what Jordan's going to talk about, is our government plans. We all know that our government passed a $2.2 trillion, that's not billion, that's trillion dollar COVID plan to make sure that the country continues to move forward. And some of it's going to industry. Rest assured, some of it will go to hospitals. But we want to make sure through our advocacy efforts that a certain amount of it goes to our practices and making sure that our practice can survive. And initially, when you go to the government or other officials, you'll get, orthopedic surgeons, they do pretty well. Why do we need to help them? Well, we all know that, yes, we do okay, thank God, but we also employ, 3 to 4 people for every surgeon that aren't, they're middle class, and they rely on us to pay their rent. They rely on us, the people that put the patients in the room, our x-ray techs, our receptionists. We rely on our practices to make ends meet. And so this is what we need, and this is what the government's realizing, and why they're going to help us out. And the devil, of course, is in the details, and that's why Jordan's going to spend some time talking about what we're doing in DC to make sure that our members get their fair share when it comes to assistance in navigating this difficult time. And probably the third most important part is communication. I think in times like these where the situation is evolving pretty rapidly, communication is very important. So we've devised a very robust communications strategy to sort of get us through this. Next slide, Jordan. So before we go on to that, I didn't want to spend a lot of time talking about the past, but I do think we should talk a little bit about our annual meeting. For those of you that don't know, the last time the annual meeting was canceled was in 1945, and I think we probably realize why that was. It was the height of World War II, and it was canceled. And at that time, the Academy had about 300 people in it. Now we have almost 30,000 people, and we spent a lot of time talking about the 2020 meeting and canceling it. We want to say this was a data-driven decision. Having said that, our number one priority was the safety of our attendings and their patients. And what does this mean? Well, doctors are treated we have a higher standard than compared to, like, if you're doing a cheerleading convention, which, by the way, was going to follow us in Orlando, or a car convention, where if a car salesman gets COVID, he's unlikely to be in contact with immunocompromised patients in a hospital and spread it to someone. So therefore, not only do we have to worry about our doctors, but also if they were asymptomatic, they could go back and work and infect patients. And frankly, and this is not a political statement, this is just the truth. 4 weeks ago, when we were dealing with this, we got no help from the government. We were in Orlando, Florida, and no one from the Tourist Bureau of Orlando or the Florida Health Department was telling us we couldn't have our meeting. So if you were waiting around to have a government authority tell you, listen, it's dangerous to have your meeting, that just didn't happen. And not that we were waiting, but it would have been nice to have some guidance. But at some point, really, common sense took place, and we realized that we really, ought not to have this meeting. And it wasn't easy, right? And frankly, no one could say now that it was the wrong decision. But this is also, and I'll just say, being in New York and what I've seen in the last 5 weeks, what you think is a difficult decision 1 week, a week later, it's an easy decision, because we've underestimated this thing when it comes to even stopping elective surgery. We stopped most elective surgery, but not all. And 2 weeks later, it's like, well, of course, you should have stopped it all at once. So we underestimated this, and we were very happy with our decision, but it was not easy. So what did we do? Well, we canceled the meeting, and we're not going to reschedule because it's technically not possible. But we did have very important functions of the meeting. Not only is our annual meeting really has three functions, right? It's educational, it's also social, and it's a business meeting. And so and there's certain business of the Academy that by our bylaws we have to conduct, and so it has to do with also making sure that the new president is sworn in, and other things like that. So we were very successful in leveraging video conferencing to do the business of the Academy. And thanks to our volunteers and our employees, our Academy staff, these video conferences went really without a hitch. From our business meetings to the BOC and BOS business meetings, it went great. And we were worried at one point we're difficult to have a quorum. We probably had just as many, if not more, folks sign in than we would have had live at the meeting. So it was great, So we're able to reduplicate that, and frankly, do a pretty good job of it. So now, how about the education? Well, that's something that we're actively working on. But we're going to have an annual meeting. We'll talk more about that lasts the whole time. So many of our members depend on the Academy for their CME. So we're going to make sure that they get their CME all throughout the year through distance and virtual learning. So, and in that, you can imagine, with 1,000 different presentations and hundreds of ICLs and seminars, it's difficult to get that all online, but we will, and people will be able to look at it and get their CME. So, but it's going to be asynchronous learning. it's good. The only thing we couldn't reduplicate is the experience you get, looking at the vendors on the floor and, catching up with your buddies and your peers, the men and women you did your residency with. Unfortunately, we couldn't do that. But I'm sure when things get better, we'll all be making up for lost time in that department. Next slide. So what are our communications? What are our goals? We want to really stay out in front of this rapidly evolving pandemic as much as you can. Again, something that was debatable or not in place a week ago is now de rigueur, right? And just personally, almost 2.5 weeks ago, I spent the weekend in New York City, and I went to a restaurant. It was open. I had drinks with some friends. I went to a couple spin classes, and thankfully, I'm still alive to talk about it. But a week later, the city was completely locked down. And the idea of going to a spin class, although when I went to my class, they did say, well, sir, the bike to the left and right will be left open for social distancing. So, which is made me feel really good. But we really want to stay in front of this. We want to also be the go-to member resource. Now we realize that we have subspecialties out there, and and they do a great job. But we want to make sure that when one of our members has a question about elective surgery, or a question about government programs, or a question about ethical decisions and rationing of care, they go to the academy. Or when one of our subspecialty societies wants to have some content on their websites about these issues, they link it to academy content. So far we've been successful about that. And the last one is really we have to advocate on a state level, on a national level, because there's a lot there that stimulus program, that $2.2 trillion seems like a lot, but there's a lot of people that are after that money, and we got to make sure that our members are kept whole, and that requires fighting. And I'll just give you an anecdote. This whole surprise billing thing has been an issue for us, right? And they keep on wanting to make surprise billing, but saying that no surprise billing, but that we're going to link your fees to the Medicare fee schedule, and we beat it down. But guess what? Part of the initial $2.2 trillion bailout had our surprise billing linked to the Medicare fee schedule. And so we were able to sniff that out and squash it. But people are always trying to do interesting things, and our folks in DC are on it, because this is a great opportunity for our academy to really be of service to its members. Next slide. Oop. Good. So we put together a resource center on our website. So it has recommendations for elective surgery, and I won't go through the recommendations, but the gist of it is that yes, we shouldn't be doing elective surgery at this point. But how do you define elective surgery? Well, because we went through this in New York, elective surgery is defined by harm will cause to the patient if the surgery is delayed. Well, that's easy and straightforward. But how do you define delayed? An hour, like a compartment syndrome, a week, a month, 2 months, 3 months. So the definition of how long you can delay that surgery before causing harm, it leaves a lot of ambiguity out there and a lot of options. And we think at the Academy, it's not for us to detail which surgeries are elective or not. It needs to be really judged at the local level, because everyone is different. And what was elective surgery in New York or Houston 3 weeks ago may not be an elective surgery now. And frankly, in another 2 or 3 weeks, if things evolve the way we think they may in New York, that we may have to even put off like infections or tendon ruptures off until things loosen up. And so we also have practice management resources, again, very important, about how to manage your practice through these difficult times. Legislative and regulatory updates, general information, and advice on practical advice as well. Next slide. Good. It's interesting too, because many of our fellows have emailed us about ethical questions and dilemmas. What happens if there's not enough ventilators and I have a hip fracture? Well, this has all been worked out already. We don't have to work this out. Since Thomas Aquinas, people have been talking about ethics of medicine and the right thing to do. And it's all about allocation of inadequate resources. And if your resources are inadequate to meet the demand, then you have to ration care. And well, how do you ration care? You got to make some difficult decisions and have difficult conversations. But our colleagues that have been doing organ transplants have been doing this for forever. There's not enough organs, so they have to make difficult decisions. And we, many of our members, a few of them, such as Dr. Casey Humbert, are experts in bioethics. Dr. Humbert, she's a foot and ankle surgeon. She's on the faculty at Johns Hopkins, and she's also a member of the Johns Hopkins Bioethics Consortium. And she's written an article and has a webinar, Bioethical Issues Surrounding Orthopedic Surgery and the COVID virus. So people can go to our website and link to this video and get all their questions answered in this webinar. So again, the idea is that if our members are stuck with this, they can actually go to our place and get ethical answers to their questions. I mean, listen, Dr. Humbert's not going to tell you what the meaning of life is, but she can tell you about how to deal with a 95-year-old who needs their hip fixed, and there's only one ventilator in the hospital. So she can help you with that, not the meaning of life. Next. So what's on next? Well, as we said, we have virtual education. So we're working on that right now. I would love to be able to tell you right now that starting in 3 days, you're going to be able to access all of the talks that were supposed to be given at the Academy and all of the symposia, but that just takes a tremendous amount of work, and we're on it, and our staff is on it. But at some point, we're going to pivot to virtual education, just like before the talk before us, Bronwyn Spira talked about virtual PT. I mean, really, this has really helped us. Yep. Next. And I'd like to sort of conclude on this, that is there a silver lining in this mess? And I like to, being a leader, you like to think the glass is half full. And I think that I know, and Bronwyn Spira talked about briefly, that the COVID epidemic is going to accelerate some disruption, right? And what disruption? Well, it's going to increase telemedicine utilization. I mean, before the epidemic, some of our younger guys were sort of dipping their toes in telemedicine. One guy would do 1 or 2, online visits utilizing Epic, but we were told you can't see new patients, you can't bill, you can't use your phone, you have to be at a computer. And, our patients were reluctant, right? And frankly, our offices were reluctant to sort of pressure them. But now what's going on? Well, yesterday I saw 15 patients via telemedicine. And you know what? They were happy to see me, and I was happy to see them. And you know what? When a total joint is at, there for their 6-week follow-up or 3-week follow-up, and they're doing fine, that can be done telemedicine. You can look at their wound, you can see their range of motion. They're happy not to come in. You're happy not to have them come in. So it's a win-win situation. Certainly, if there's an issue, you have to be able to see them in person. But I think that this is really going to give a boost to telemedicine utilization. And the government has relaxed a lot of its regulations about telemedicine. They relaxed a lot of the HIPAA things. And you know what? The lawyers at our hospitals relaxed a little bit of their their concerns too. So we could bill for telemedicine visits. We can do them on our cell phones as long as it's on the platform. And our patients are accepting this concept. And you know what? They're going to probably like it. So again, I don't think we'll ever go back to not using telemedicine. We'll be able to see patients in our office when we have to, but this has really been a transformative occurrence for telemedicine, which I believe is a good thing. It allows access to vulnerable populations. It also decreases horizontal disease transmission. I mean, you got sick people in your waiting room. It's not great, right? We all know that with COVID. And the other one, which is not quite as sanguine about, I'm not quite as sanguine about, is it's going to accelerate industry consolidation. And what I mean by that is, unfortunately, some of the smaller practices may, if they survive, they'll survive, hopefully. But some of their members say that was a close call. I think that joining the mega group next door seems like a pretty good idea. So I think it'll help horizontal consolidation and the growth of big groups. Also, I think, it will, not I think, it will also sort of accelerate vertical consolidation. Same reason. Here's a group and some guys, and they realize, man, how vulnerable they really are to a problem. And you know what? Joining and being an employee of the hospital may not seem like a bad thing. You lose some independence, but at least you don't have to worry about, if you don't see patients for 2 weeks, laying off your staff. So again, I think that it will sort of accelerate industry consolidation. And I'm not prepared to say that's good or bad. I just think it's a fact, and it's a fact that we can't go back from. Next. So this is just a summary of our action plan. So we have external changes, cancellation of elective surgery. We're expanding telemedicine. And what happens when it's all done and we can get back to operating? How are we going to navigate that? That's because, I think, at least in our area, our nurses are that work in our surgery centers and that work in our hospitals, our ORs, they've been repurposed. They're on the floors working 12-hour shifts. Plus, our pulse oxes, our ventilators are scattered all over the hospital system. So the minute things get better, it's not like we can go full speed ahead. We're going to probably have to do this in increments. But so we're working on helping our folks navigate that. And then, we are, again, working with the government to really make sure that this $2.2 trillion stimulus really has enough for the physicians that are struggling to maintain their practices and, frankly, pay their employees that really depend on those practices. And we're going to get in front. We're going to do a email every Monday morning, a little letter from the president to sort of go through what transpired over the weekend and let people know how things are going. This Thursday, a week from today, we're going to have a webinar where people can ask questions. I mean, there won't be 4,200 people like you guys have, but we'll get a fair amount. And so again, just so folks can ask questions. And again, because what's true today, from my experience, what's true today with this thing is going to be false in a week. Things are evolving rapidly, and we're on it. And I'm really proud of our organization, your organization, and its ability. The big organization has pivoted off of the strategic plan and really gone all hands on deck on COVID. So rest assured that you and our patients and our practices will be well taken care of. And with that, I'll throw it over to Jordan, and he'll talk, and then we've got time for questions. Thank you.
Okay, thanks so much, Dr. Bosco. I appreciate it. My name is Jordan Vivian with the AAOS Office of Government Relations, and I'm going to kind of go over some of our highlights for our advocacy so far, and then look forward to your questions. So quickly, I just want to say, as Dr. Bosco said, AAOS Office of Government Relations is really working with Congress and the agencies with a tight focus. We're trying to ensure that our physicians, their practices, and their patients get safely through this crisis, and you're able to continue providing high-quality musculoskeletal care during the crisis and in the transition back to normalcy. Everything we do is aimed at that goal. So I want to start with some of the highlights of our advocacy efforts so far before we go through the individual packages. One of the first things to hit was HIPAA flexibility. This is no enforcement of rules against good faith attempts to provide telehealth. This is why FaceTime and other commercial platforms you see are now being used and allowed and really enjoyed by the patients who suddenly find it significantly more accessible, and the physicians to use these telehealth platforms. Next was the delay in the 2019 performance year MIPS reporting deadline. We believe that there's more coming when it comes to trying to help physicians that are in the bundles, make sure that those that took on this additional risk to provide this additional value aren't punished because of this crisis. This specific decision means that any MIPS eligible clinician who doesn't report by April 30th, which is the new deadline, they get a neutral judgment, no penalties, no bonuses. We're going to continue working on that and look forward to continue changes and flexibility from CMS when it comes to the bundles. So next is the Good SAM protections. This is something we've been working on for a long time. This is essentially a mini version of the Good Samaritan Health Professionals Act. It's been a key priority for a while. This is temporary liability protections for volunteers crossing state lines, specifically to treat COVID-19 patients. We hope to build on this. The Good Samaritan Health Professionals Act is more general, and it refers to any federally declared disaster. We're hoping that following this crisis, we can say, see, these protections work. They draw physicians to the areas where they need to be, and we hope to expand this. And then I want to talk about federal support for physician practices. This is obviously a key priority for us. I don't want to overstate what we got signed into law, as you see there, March 27th, as part of the CARES Act, which we'll talk about. It's not perfect, it's not done, and it's limited. This is the beginning of a long process. I do want to quickly go over some of the specifics. There are 2 small business administration loans involved in this federal support. There's the Paycheck Protection Program and the Economic Injury Disaster Loans. We have a great guide on our website, as Dr. Bosco referred to. It's AAOS.org/COVID-19, and we have a whole resource guide, and something on there is a great backgrounder. It's just a few pages long on the specifics of these programs, who's eligible, how to apply. I encourage you to look at that. It's very informative. But what you need to know about these programs is you need to be under 500 employees. There's an exception under the affiliate rule, but most healthcare industry providers don't qualify, so you need to be under that 500 employees. The basics is the Paycheck Protection Program is designed to incentivize you to keep your employees on payroll, and it's therefore forgivable if you meet certain specific restrictions on keeping your employees on payroll. And then the other is the Economic Injury Disaster Loans. That's up to $10,000. It's not forgivable. The idea is it's a bridge loan to get you through for a little while. It's up to $10,000, like I said. And then also, Dr. Bosco referred to the $2.2 trillion CARES Act, which I'll talk about in a second, but there's $100 billion in that, and we were able to work along with our physician partners in making sure that physicians were a part of that package. HHS is going to decide very soon in the coming days how to distribute that $100 billion. We expect most of it will go to hospitals, but physicians have not been carved out of that. So we're going to work to make sure that those of you that have essentially shut down your practices because you're not doing elective surgery, that there is money in there to make sure that it can keep you going as well. So we're going to continue to work on those programs. A quick note here on the support. We just sent out an email just this afternoon to all U.S. AAOS members with a survey with some information on what we're doing, as well as a survey. And I really want to give that a shout out and ask you to please respond to that. It'll also be up on our AAOS.org/COVID-19 website. We really need that data. We need to know what's happening to you all on the ground. What's the specifics in your practice? What is your situation? That will really help inform our efforts moving forward. So just a quick shout out to that. Also, moving on to the 2% Medicare cuts. This is the first step towards lessening the financial burden on Medicare providers. Like I said, we're continuing to work on more, but all these little changes we hope will add up. And then finally, an expansion has been allowed for physician-owned hospitals. This is also a long-time priority of AAOS. As many of you know, physician-owned hospitals were prevented from growing or expanding by the ACA. This temporarily allows POHs to add or convert beds in order to respond to patient surge, specifically during this emergency. And the waiver that CMS issued on the 30th also applies to other Stark Law restrictions, which is physician self-referral law. Essentially, they're not going to charge anybody acting in good faith until after the crisis is over. We're going to be looking for this to be slowly rolled back as opposed to just shut down on one particular day. As we move forward here. Next, I want to talk about some of the other congressional action and administration action that's happened so far. So Congress has done 3 phases of emergency appropriations. The biggest one, the one that most people have been talking about, that Dr. Bosco referred to, is the $2.2 trillion CARES Act. Just to put that in context for you, the entire budget, the entire expenditures of the federal government was $4.4 trillion last year. So 2.2 is a significant amount of money. It's an historic rescue package. I already mentioned the $100 billion for hospitals and providers. Those regs are getting written very soon. We're going to be fighting to make sure that physicians get access to that. Also a telehealth waiver for Medicare. Essentially, all statutory requirements on telehealth for Medicare are either being waived or kind of look the other way right now, as long as you're acting in good faith. And then also this $500 billion corporate liquidity with oversight. House Democrats really made sure that there are strings attached to that. That was a major piece of the CARES Act, as well as a 20% bump for COVID-19 related treatment from the federal payers. And then in terms of administration action, some other things you need to know about is this advanced Medicare payments. So the issue with this is that Medicare is going to be requiring recoupment of this after 120 days. So we feel like if this crisis continues past that, we may need some flexibility when it comes to that recoupment. Obviously, if you're not doing elective surgeries, you're not going to be able to return that payment. If the idea is it's advancing what you're doing. So if you're not doing any surgeries, then you're going to have an issue with that 120 days. So we're looking to expand that. It's still very fluid, but we do think that's something that some of our physicians will be able to take advantage of. Also, the FCC, this is still a proposal, but reports are that they have the votes in the FCC. They should be moving on this soon. This $200 million is from the CARES Act, and this is specifically for providers to kind of expand their health IT, expand their telehealth capability. Also, prior authorization flexibility is a huge priority for AAOS. What we've seen is that all the states, at last check, I believe it was about 41 states that have applied to Medicare for these 1135 waivers have been granted prior authorization flexibility. We've also seen a couple of private payers, I saw just today, announced some flexibility with prior authorization. So this is something that we'll continue to work on and continue to expand on. Also expanded capability for ambulatory surgery centers. ASCs are now being paid at the hospital rate, allowed to expand their capacity, and they can contract to provide hospital services in partnership with the local healthcare system. This is something that we hope will continue to ease the burden on some particularly burdened hospital systems. So here's some of our additional goals that we have when it comes to our advocacy efforts for COVID-19. I already mentioned some of the gaps that we feel like in CARES, where we're working to continue to flesh that out and build those out. We're working to do two things in particular in terms of financial support. Number one, we need to assess the need. So I mentioned that survey. Please fill that out. You can really help us better understand what you need. We're also working to advance legislation that provides immediate grants to practices that are no longer doing elective surgery. There's a bill that we're working on that would essentially give you an immediate grant for 3 months of payroll. That's a big part of our congressional advocacy. In terms of CMS, we're continuing to work to lift the burden on physicians in every way we can, especially those who took the risk to participate in those bundles. We don't believe you should be punished for doing the right thing, stopping elective surgeries. CMS is looking into this. They're going to be reaching out to participants and conveners soon for BPCI Advanced and the other bundles. Much of those episodes are elective. They understand that. So we're going to continue to work very closely with them. Finally, we wrote a letter to the Vice President and the White House Task Force, and we're going to be working with them to streamline the PPA distribution, get our frontline providers what they need, as well as get guidance from CDC on what protective measures our surgeons need to take when operating on COVID-19 patients. So just quickly here, I know we want to have time for Q&A. This is what we anticipate for future federal action. We know that there will likely be a phase 4 COVID-19 bill. Congress right now is supposed to come back on the 20th. I don't believe anybody thinks that they will come back then. So we'll see. I know many members of Congress do not want to return to DC. A lot of the House members were pretty upset that they had to come back just to pass CARES because they were already out of town. Nobody really wants to come back and put themselves in that situation. So that's definitely an element. There's only a limited amount of things they can do by unanimous consent around here. So you need to have actual people in the building. But we believe phase 4 will revolve around healthcare, and it may revolve around infrastructure. There's a lot of talks going on between House Democrats and the president, who are both obviously definitely want a large infrastructure package. Finally, I mentioned that bill, the Immediate Relief for Rural Facilities and Providers Act. That's a bill that we continue to work on. That's that 3-month payroll supplement grant, and we're going to try to get that done as soon as possible as well. When it comes to administration action, we expect the administration is going to continue to roll back rules and regulations to the extent they can. We're going to keep working to protect our surgeon, and we're looking at these guidance windows for CARES starting to close. So the federal agencies are going to start providing us essentially a better idea of how the CARES funding is going to be distributed, like I mentioned with HHS and SBA and other organizations. So we're following that very closely. We're also looking for that guidance on surgical team protection. Finally here, last slide is, I just want to do one more shout out for the resources we have available on our website. This is just a few of them. This coding guide, telemedicine policy tracker. I really encourage you to look because there's a lot of very useful tools on our website, and we continue to update it around the clock. So I encourage you to check that out. And finally, we're happy to take any questions. I've got my email address up there. If there are any questions that you'd like to ask in private or specifically, please feel free to shoot me an email. I'm happy to direct you to the person that can answer your question. Thanks so much.
Thank you, Jordan. I'm going to come back on and bring Dr. Bosco back on and close out our slide deck here. Ooh, things got dark in New York all of a sudden.
Darth Vader. Here we go.
Well, welcome back, everybody. So now we get a chance to ask you questions and also remind people that if that talk from Jordan and Vivian got you a little confused, there's a lot of information. It is available on immediate replay directly after this event from this platform, also on YouTube and Facebook. So this information lives on, is accessible to all of you as necessary. So I'm going to start with a quick roll of the questions and see how they go. So this is from one of our attendees. What is the AAOS guidance on elective surgery, especially joint replacement, sports and spine surgery for the rest of the year, especially at ASCs who aren't handling COVID patients? Do we have guidance about when to return? As yet, it may be this a little bit too early.
Well, you know what? That's a great question, and so, certainly one which actually Danny Guy, our first vice president, and Buddy Savoie, our second vice president, I have just put together a guide, and it's going to probably be on our help site probably tomorrow morning. So again, as I reiterated, there are definitions of what constitutes an elective surgery, and frankly, I'll just tell you our experience is, okay, so spine surgery, we have to ask the spine surgeon. So when we first asked them for the definition of elective surgery for spine surgery or emergent surgery, we got things like, well, a person with myelopathy with a T2 signal in the cord. All right, so for a sports guy like me, it's like, whatever. Sure. I guess that sounds good. In all honesty, so those questions are best answered by the experts. So what we thought that was probably more non-elective than elective. Now, of course, those patients aren't getting done because they can wait. And how long can they wait before harm comes? A month, probably. 3 months, probably not. So again, it's got to be locally determined. And to ask your question, I will tell you that we have a six OR surgery center, and we do about 7,500 orthopedic cases there a year. And we were running it until a week and a half ago, and we shut it down. Why is that? Because you're right. It's not part of the hospital, but you're bringing people in there. You can't social distance them, right? Second of all, you are using resources that could probably be better off in the hospital, like masks, like gowns, like ventilators, right? You don't have enough ventilators. Well, our surgery center had 6 rooms. We had 8 ventilators. You know what? They're not there anymore. They're in the main hospital. So theoretically, sure, you could do a knee scope, and you use 5 or 6 masks and a couple gowns. That's not going to break the system, but you can't socially isolate those patients, right? You're putting your OR staff, and there's only a finite amount of nurses, and our nurses have been repurposed. So the long-winded answer is, theoretically, you could do it in a surgery center. It wouldn't harm anyone, but you're diverting resources. You're exposing patients and staff to the virus. And it's just, it just doesn't look good, and the optics aren't good. So the bottom line is, for us, we canceled our elective surgeries in our surgery center.
Dr. Bosco, let me just ask a question that sort of came to mind as I was thinking about the fact that we're working on guidelines. Has the Academy thought about reaching out to whether it's the Chinese Orthopaedic Association or other associations in Europe that are actively have experience now, a month, 2 months of experience, but still experience with this to help create, or NHS for that matter, to create guidelines that are sort of based on the experience we've seen elsewhere. Framing that question is the fact that cities that learned from the Asian and the European experience are shut down early have seen much lower rates of COVID than cities that delayed action. Similarly, it would seem that we could learn from other societies and help have more of a global than an isolation or term, but than an internal perspective on this. Is there potential to do that?
Well, I think you're absolutely right. There is that potential. And I will tell you, just not so far in this country has been overreaction to the COVID virus. Everything has been not enough, but it's been made with the right criteria in mind. It just says, as this thing evolved quickly, it's evolved a lot quicker and worse than we ever thought it would be. So we are reaching out to other countries, especially Italy, to see exactly how they dealt with this, and frankly, how they're going to start things back up. Again, at some point, this is going to go away, or we're going to have to start back up again. But what does that look like? We're not entirely sure. So, yeah, was it a bad idea to have the Mardi Gras parade in New Orleans 4 weeks ago? Probably yes. Was it a bad idea to have the Chinese New Year's parade in New York City 6 weeks ago? Looking back, probably yes. But at that time, no one thought it was a bad idea. So we're learning.
Thank you for the answer. Jordan, question for me. What is the likelihood that small private practices have access to the $200 billion that is earmarked for healthcare organizations? And do you have any indications to how your proposed academy legislation for small, medium-sized practices will interact with the payroll protection portion of the CARES Act? Complex question. I'm sure you understood it better than I did. This is from Dr. Andrew Shadid.
Sure, absolutely. Great question. So we know that $100 billion that I think you're referring to that was in CARES will largely go to hospitals. However, we also know that there was an effort to cut physicians out of that entirely. That effort was not successful. We also know that Speaker Pelosi wanted a more specific language saying that money was meant for practices and physicians that were essentially not doing elective surgeries for the public good. So we know that congressional intent is for that money to go to, at least some of it, go to physicians. However, you're absolutely right. We honestly don't know. We don't know. I don't have the answer to that yet because a lot of it will be up to HHS. That's why we're working closely with HHS, commenting wherever we can, and making sure that we take advantage of every opportunity to push for that inclusion. But unfortunately, the short answer is we just don't know it yet. We will in the next few days.
Dr. Bosco, quick question for you. I want to get it back to the technology around COVID-19. And you said that today, I think you mentioned you saw 15 patients using telehealth platform. The question that came up was, what would be your normal in the same time frame during which because you weren't, that's not the whole thing you were doing, but in the time frame that you were doing telehealth, how many patients you would normally have seen in a normal clinic if you saw 15?
You know what? That's a great question. So most of these were easy follow-ups, right? No one had any big problems, or else they would have come in. And I didn't have my PA with me. So you know what? It was the first time I did it. It was pretty good. Plus, frankly, in a crisis situation like this, there's everyone, they've studied this a lot during the Blitz, during World War II, and during 9/11. There's a lot of altruism, right? So patients are very happy. They're not going to complain about things they usually complain about. So I think it's difficult to say, but my guess is when things get rolling, it's not going to take any longer to see these folks. It may take shorter time. They don't have to get in the room and everything. So I didn't see that it took me any longer. And that 15 was just all the ones that wanted to do it, and all the ones that we could get a hold of.
Right. And also the Academy is thinking about embracing more platforms like this one, like we did today with this conference as we move forward. So I expect that you're absolutely right. There's no turning back the technology. Once people have had a chance to experience it, they'll probably be looking for it, especially now that the barriers have been largely removed to accessing them that existed before in the United States.
Stefan, once all told guys like me get used to using it. We're forced to use it. We figure it's not the devil. And actually, it's pretty good, right? And the concept of flying into Chicago to have a meeting with the group, really, that's not great for carbon footprints. And you know what? We probably can just do it online. There's a little less intimacy, but we can get around that.
Yeah, absolutely. The value of that interpersonal relationship and that meeting certainly doesn't go away, but it does give us more possibilities. Through the I belong to American Association of Hip and Knee Surgeons, and we just created a platform for under Bill Hamilton's leadership to basically bring all the fellowship lectures that are happening around the United States to the other fellows in the United States. Something that would have been something we could have done 6 months ago, didn't really do it, but now that it's done, I can't imagine we'll ever stop doing it.
Yep.
These technologies, once you have the impetus, the time. So quick question for yourself. You're in New York City. You're the height of this. You mentioned a little bit your experience so far. The sports practices are probably not much different than all the other orthopedic practices, completely shut down, as you mentioned. How are you living it? How's your department living it? We'll talk to Rand Schwarzkopf in a minute, but any thoughts about learnings from this experience that you'd like to share with us?
Sure. So, we have a very big department, 135 active orthopedic surgeons, 3 major hospitals, 30 centers. So you know what? Frankly, the vast majority of people in our department, physicians, wanted to do something. But what does an orthopedic surgeon do during this? We have a very vertically defined skill set. So, we were making our guys take shifts in our orthopedic. We had an orthopedic ER, but you know what? No one was coming. So now, starting this week, we're going to do 12-hour shifts on the floor, taking care of patients. Our orthopedic hospital, which has 100 beds, has been converted to basically a COVID hospital. So we're going to be on the floor because our PAs and our nurse practitioners and our OR staff is on the floors taking care of those patients, and we've been repurposed. And you know what? It's got fitted for my N95 mask. We got fitted 2 years ago, but we didn't pay attention because who was paying attention 2 years ago? It's like 5th grade. I wish I had paid more attention. So I got refitted, and I passed the test, and we're going to go back up on the floor. And you know what? We're going to what Dr. Zuckerman has said is that everyone in our department has to contribute. Now, if you're over 65 or have a health problem, well, then you're not going to go on the floors, right? But you could do virtual health. You can do virtual visits. We're doing that. So, and you know what? I think you'll find that in times like this, people want to do something. People want to help.
Yeah, and we've seen orthopedic surgeons across the country helping with their clinics. Another thing that you just mentioned that I think is very common is and I've heard this from colleagues in Germany, colleagues in Italy, colleagues in England, that we interviewed for our podcast recently, was that a lot of the orthopedic hospitals, given that essentially we've been shut down, have been converted into COVID hospitals and as a place to take and manage these patients. So that's also something that we're seeing commonly happen across the world, really.
Right. Yep.
Quick question for Jordan.
Yeah.
From Dr. Leslie Anderson, right here in the Bay Area. Thank you, Dr. Anderson, for your question. What is the Paycheck Protection Program, and is it different from CARES?
Sure. Well, thanks for giving me the opportunity to talk about that. I see that there's some confusion in the chat as well, so I appreciate the opportunity to clarify. So we're really talking about 2 pots of money. They were all provided by CARES. The CARES is that $2.2 trillion bill that Dr. Bosco referred to. There's the Small Business Administration money, and then there's the HHS money. The HHS is that $100 billion that I was talking about. We're trying to make sure providers can get access to that. It's mostly going to go to hospitals. When we talk about the Small Business Administration money, that's the Paycheck Protection Program and the EIDL, the Economic Injury Disaster Loans. Those are both through the Small Business Administration. It's helpful to separate them out by agency. And that Paycheck Protection Program, that's that up to $10 million, but it's based on your payroll. And essentially, it's forgivable if you meet certain restrictions when it comes to not laying off your employees, keeping your employee count about the same at the end of the crisis as it was before. And the Economic Injury Disaster Loans is that $10,000 immediate, more of a bridge loan type situation. That's not forgivable. So to answer your question, the Paycheck Protection Program was expanded and built out by CARES.
I don't see any further questions in the chat. I think we've really gone over the amazing resources the Academy is making available to us. Dr. Bosco, we thank you for that. We are excited to see a leap into this new world of digital. At the Digital Orthopedics Conference, we've been running that for 4 years. We've been trying to get people's attention around this issue that is going to be a tool that we can use to help improve the care we have. And now that we've all experienced, I think it will be more easier for us to get that message to our membership. The explanations that Jordan, you gave us relative to all that's happening around CMS and government intervention and the Academy's efforts on our behalf are really beautifully presented, and thank you for doing so. And with that, I want to thank both of you for participating, and again, the Academy for joining us at DOCSF, and again, supported by our department here in orthopedic surgery at UCSF. We're super excited to be able to work together and maybe continue to do so in the future.
Thank you.
Thank
you, sir. Much appreciated. With that, I will go. We're going to go to a session with Tom Barber, who is in New York, along with Rand Schwarzkopf, both orthopedic surgeons. Both of them probably very familiar to all of you, and they'll tell us what it's like to live in the sun epidemic, much as Dr. Bosco is doing, and share that experience with us and get down to details. So we'll see you there in that room in that next session. Thank you both very much. Have a great day and stay safe.
you. You too.
Thank you.